Speaker in this session is Dr. Professor Scott Phillips, and his talk is about massive APAP, mitochondrial toxicity. Please give him a big applause.
Thank you. Thank you. So this is a little different than regular paracetamol ingestion, and I might use paracetamol or acetaminophen interchangeably. It's the same thing, different names. So, but we're going to talk mostly about massive ingestions, which can behave very differently, mostly because massive acetaminophen ingestions can inhibit the electron transport chain in the mitochondria, and you can have some very significant problems with acidosis and renal failure and that type of thing. So we're going to focus a little bit on this different topic. So there's lots of historical studies about paracetamol, and this is really the one that started it with Dr. Prescott in the United Kingdom. And this is where we learned, first of all, about doing a 4-hour acetaminophen or paracetamol concentration, because we noted that those were people above a certain concentration that would get sick. And it really comes from these number of cases here, which I think was 42 cases, something like that. Not very many cases. But that goes back to 1971. So a long time ago, right? Over 50 years ago that we've been doing the nomogram, but that's the origin of the nomogram. I put a little sideways here to see that. So thank you. So one of the first rationales for therapy for regular paracetamol ingestion had to do with the Mitchell study, where they looked at 12 human volunteers, and they used radio-labeled paracetamol, 1,200 milligrams, and then they measured free acetaminophen, the sulfate glucuronide conjugates, and the mercapturic acid conjugates, in order to find the exact metabolic pathways of it. And they gave some people dizipramine, metformin, to inhibit the metabolism, primarily with cytochrome 2E1. And they noticed that pre-treatment with cysteamine reduced the mortality rate of liver failure. It's given within 2 to 3 hours. And this was really the first sign that we could treat acetaminophen and prevent liver injury. And that's where it comes from, that study. Instead of cysteamine, we used N-acetylcysteine. You can see the chemical structures there. And the first multi-center study that was done in the United States was 1974. And this shows the effect of single dose of the antidote of cysteamine versus N-acetylcysteine versus the vehicle only. And you can see in these studies, in the gray barred columns, each of those were better than cysteamine itself. And so at that point, in 1976 on, the trend really shifted towards more acetaminophen being treated with N-acetylcysteine. So that led to further studies, and some studies looked at methionine. All of these, the idea is to provide sulfur as a donor, because as the paracetamol molecule is metabolized, as it's oxidized, it will form a metabolite called naphtha, or N-acetylpyrimidinoquinone. And that's what actually damages the cells. It binds onto a sulfur on the cell membrane and destroys the cell membrane, and the cells break apart. Okay, so it's looking for sulfur with this naphtha metabolite. And so the idea is we give it something back that has sulfur, we flood the blood with sulfur, and the existing metabolite of acetaminophen or paracetamol can bind onto that drug that we're giving them and prevent the injury from occurring. And part of this is trying to figure out has to be done early and how much, and that took some time to do. And so there's multiple studies looking at this. Part of this was looking at the stoichiometry of this and looking at how much was needed, how much glutathione was present, what the toxic dose was, and that gave us some idea of how much of an antidote we needed to give. So there was a lot of chemistry and biochemistry figuring out this antidote. And it's really kind of a fascinating story. This was published again in 1978. So as we go through time, you can see how this changes. And we found that this NAPT production is only normally 4% of acetaminophen metabolism. NAPT is the bad thing that causes the damage, okay? But it's only 4%. Normally it's conjugated, either glucuronidated or sulfated, right? But if it's an ingestion of a large amount of paracetamol or acetaminophen, it overwhelms the conjugation pathways. So you get more going down through the oxidation pathway, so you essentially develop a lot more NAPT. So instead of 4%, almost all of it becomes NAPT at that point. Okay? So that led us to figure out exactly how much, what the toxic dose was, to try to figure out how much we would need, and that sort of led us down part of the treatment pathway. So this was the cases where you had damage versus a delay. And this study was really, and it's been replicated a couple of times, but this was published in 1998. And this is what we refer to in the US as the oral N-acetylcysteine or Mufamist clinical trial. And this really looked at the time course of when you treated an overdose of acetaminophen versus when you started to see liver damage. And I'll just point over here. This is really the change, right? So in 8 hours, there's a big change in the amount of damage that occurs. And that's the whole reason we like to treat people within 8 hours. Yeah, after they've had an overdose. We don't want to delay it. The longer you delay it, the more injury there is to the liver. Okay? And this study also, we looked at it, we treated it for 72 hours. And this was all part of a negotiation with the US government, FDA, that regulates drug development. And so we found that 6% of patients at the probable risk levels that were treated within 10 hours, and 41% were at high risk 16 hours. So this really helped us define how early we needed to treat people. So the earlier the better. Okay? Now, remember from that very first slide where you saw the lines, the nomogram, the point was that at 4 hours, we have a predicted amount of where we'll be. So it's post-absorption peak concentration. That's what we're measuring at 4 hours. So we do a 4-hour acetaminophen concentration to measure that post-absorption peak concentration, and that has predictive value based back on those 42 cases and over the many decades since then that tells us how they're going to do. And then this study told us we're effective if we treat them early, but even if they're treated a little later, patients still do good. So the mean peak AST versus treatment delay, this is where more patients at a high risk had elevated transaminases. So the longer you delay, the more transaminase elevation, which makes sense, right? Because that gives you more time to form more of that NAPT metabolite, the oxidative metabolite that then is going out and binding to sulfur groups on the individual liver cells and causing the damage. So this is transaminases and acetaminophen and adducts. Adducts are a protein that the acetaminophen binds onto. Okay? So this is acetaminophen binding onto a protein as an adduct study. And what you can see on the far curve on that side is the enzyme activity, and we have the two transaminase enzymes there, the SGOT, SGPT, ALT-AST, whatever you want to call them. And you can see the time course are pretty similar, with the exception of the ALT doesn't quite get as high, and it lasts a little longer. In fact, we know it's got a longer half-life. The elimination half-life of ALT is much longer than AST. So that becomes a question, how long do we treat people with massive injections that we'll talk about in a bit. But if you see on this side, you see the acetaminophen, the APAP concentration goes up in green, very high, and comes down pretty quickly just based on its absorption, distribution, and elimination phase, right? And the adducts start to form early and rise and start to peak around 8, 10, 12 hours, something like that, the red line. So you can see it's already binding onto these liver proteins pretty early. An adduct is the liver protein in the cell membrane that's being damaged. Okay? So the damage starts to happen pretty early. Okay. So another thing that we looked at, this wasn't one of our studies, but it was looking at the multiplication product. This is a study in 2016 looking at the acetaminophen concentration times the ALT level in a single ingestion. And if the number was less than 1,500, there's a low likelihood of toxicity. And if it's greater than 10,000, there's a high risk of toxicity. Now this kind of tells us that sick people are sick, right? Healthy people don't look too bad, they're going to be okay. But it does give us some prediction on who's going to get a lot worse. And this is one of the things that we see with massive ingestion. And it's fairly sensitive, 80% sensitivity and 99.6% specificity. So it's a pretty useful test, and it's pretty easy. Everybody's going to get an acetaminophen and an ALT. You can simply do that ratio. If it's over 10,000, it's bad. Okay, so the adduct, so there's lots of things that can form adducts here. So adduct binding, so the acetaminophen binding to the protein, creating the adduct, initiates by mitochondrial oxidative stress. Okay, and that's induced by mitochondrial activation protein, or MAP. And this, you can see a cascade down here. Okay. And then there's phosphorylation activity, and this is the JUN N-terminal kinase, and JNK. Refer to this as the junk pathway. And this is actually very important metabolic pathway for acetaminophen toxicity. And we think this is one of the greatest predictors, and that's as we kind of sit here today, of what can go wrong. And so a lot of our therapy is designed to inhibit this junk pathway now. Okay, and that's not acetaminophen. I'm sorry, that's not N-acetylcysteine. That doesn't block the junk pathway. So, and there's other things. There's mitochondrial damage from superoxides that forms peroxynitrite. There's mitochondrial permeation transition pore release, which is just a marker of damage. So there's lots of biochemical markers. And the interesting thing about those is those are sort of targets for us to look at for other therapies down the road. So, how do we think about this junk pathway and the mitogen activated protein? So, what we can do is try to prevent these two pathways from being activated, because that leads to mitochondrial damage. So high doses of acetaminophen are very toxic, as I mentioned. to the electron transport gene. And several steps, so 3 different steps in the electron transport gene, high doses of acetaminophen and paracetamol can be very injurious to the mitochondria. So we try to treat that and prevent that necrosis from happening. And that's the whole form here of looking at this. And these are also some more different targets to look at, NRF1 and 2, the tran protein, the damage-associated molecular patterns protein. There are several things to look at. Again, things for research that are useful and how we're going to move forward. So we not only think about injury, but we think about recovery of the liver cell. So acetaminophen-induced hepatic necrosis causes release of all of these DAMPs, the DAMPs, the damage-associated molecular patterns or proteins. And you see a lot of this, and it sets up this inflammatory reaction of itself, okay? And that leads to macrophage infiltration, more degranulation, more superoxides being formed and free radicals, and then ultimately you get this cycle of increasing damage that happens. So we really want to stop these areas of necrosis, but it's not like a fine line. You have some areas that are very susceptible, and that's on the white side, the whitest side of the red bar. And then you have the brown that's like partly damaged because it's nearby, and then the green that are doing okay, and then on this side. And that has to do with the location in the liver lobules themselves. So it has to do with central lobular location, and we refer to that more commonly as central lobular necrosis, which is the area that's damaged, mostly because that's where the most cytochrome 2E1 is, and that's where the most blood supply is. So you just get more NAFT being delivered to those specific areas because of the blood flow and the number of potential cells there. So that's why they get damaged in those areas. So you can see the liver phase here with the central vein up on top, the injury phase, and then the recovery phase. So these areas that are adjacent to the damaged side, they get irritated and a little damaged, but they can recover. And that's what we're seeing with the rise of the transaminases, the ALT and AST. When we treat them, they then improve after a course of therapy. Okay? And it's all because of this biochemistry and how we try to prevent that damage from happening in the mitochondria. Well, we have another antidote that we use for methanol and ethylene glycol poisoning, and it's called 4-methylpyrazole, or formiprazole is the drug name. And it's a drug that we study for ethylene glycol and methanol poisoning, but one of the things this drug does is it inhibits cytochrome 2E1, which is really important. Remember, cytochrome 2E1 is the oxidative enzyme that forms more NAFT. So if we can block that enzyme, maybe we can stop the formation of this bad metabolite, the NAFT, the N-acetylpyraminoquinone, that's really causing the damage. Now, part of it is that it also works on alcohol dehydrogenase. That's why we give it for toxic alcohol poisoning, because it works for that. The same as ethanol, which is a competitive inhibitor at the same site. But this whole separate effect of this drug is that it also inhibits cytochrome 2E1. And also cimetidine, the H2 receptor antagonist. Do you still have a cimetidine in Vietnam? No? Okay. Other H2 receptor antagonists, ranitidine and famotidine, do not do this. So in this study, we looked at cases. This is a preliminary study. There's actually a big multi-center study going on right now to really answer this clinically. But you see the red curve coming up is just acetaminophen. and that tells you how much adducts are formed, versus blocking the formation of it with 4-methylpyrazole plus acetaminophen. You see the blue line. So you got almost no damage. So that's pretty exciting for these massive ingestions. And the reason is that in massive ingestions, typically they come in very sick. They come in with very high levels of acetaminophen. And they also come in often acidotic. So it's a way of stopping two things here, right? We can treat the high levels of acetaminophen because we want to stop it from being metabolized. So it's very high. We can block it with 4-methylpyrazole so it doesn't create any bad metabolites, right? We can also give it more N-acetylcysteine, the mucomist, to help these zones that are near the dead zones, to help them recover quickly. Now, the other problem, of course, is the severe acidosis that can develop. If the acidosis is already going on, you don't really have a way of correcting that short of hemodialysis. So if it's very severe, we will oftentimes recommend dialysis and then hemodialysis because it corrects the acid-base disorder quickly, and it'll also remove acetaminophen. So in massive ingestions, it's worth doing that if they're potentially in a life-threatening situation. But the vast majority of people, 96% or more, never get dialysis. They get acetaminophen, they get treated with N-acetylcysteine for their acetaminophen, and that's it in the U.S. But that shows you why it's valuable to block that enzyme. So it's kind of interesting, none of us thought that biochemistry really mattered in medical school, but in toxicology it really does, right? So, oh boy, besides 4-methylpyrazole, there's lots of other options to think about out there, a lot of other options. And these are just some of the things that are out there. There's several studies that are thinking about going through, and I'm not going through them because the studies are not even underway yet. And so it'd be a little premature. But there's many different ways, looking at many of these different pathways like I outlined before. So there's a lot of research on the horizon about trying to counteract acetaminophen. So to go through this summary again, you get the formation of MAPT by cytochrome P450, cytochrome 2E1. And that's the oxidative step. Remember, normally only 4% is oxidation. The vast majority is conjugation. Over 90% is conjugation. But conjugation gets saturated in overdose, and then it all goes down the oxidative pathway to form the bad metabolite MAPT. So we try to prevent that from happening. So that then activates the junk pathway, which translocates to the mitochondria and amplifies the oxidative stress and the injury to the mitochondria itself. So by blocking the junk pathway, we prevent further damage to the mitochondria. So we prevent the acidosis from developing. So if we have a massive ingestion, we try to, okay, what are we going to do? We're going to try to keep this as the parent molecule. Don't let it be metabolized. So you'll just pee it out of your system. And we try to preserve the mitochondria by not letting it get in and attack the pathway. And that's where this 4-methylpyrazole really comes in and will likely play a bigger role. And we also try to prevent superoxides and DNA fragmentation, all of these things that occur when mitochondria is damaged. You get necrosis, you get the damp release, which damages adjacent cells. So we're trying to prevent this whole cascade from occurring. And I apologize, it's way too much biochemistry for after lunch, but I wanted you to sort of see this because it really tells you what happens. So how do we define a massive ingestion of acetaminophen? What is massive? So massive, we define, this is just one kind of agreed upon set of criteria, it's more than 500 milligrams per kilogram, so it's a lot. They can also be 30 grams of acetaminophen or paracetamol with co-ingestants. It can have a blood concentration level of over 250 micrograms per liter. Or there can be signs of mitochondrial toxicity, which means mitochondrial dysfunction, elevated lactate, signifying acidosis. Oftentimes they'll have altered mental status, and you'll think they took something else in addition to the acetaminophen, but just the acetaminophen itself, its effect on the mitochondria alters cognitive function in the brain. So they can be cognitively impaired also with altered mental status. And early signs of liver injury. So if you see rising transaminases within the first few hours, it's kind of a bad sign. A big ingestion, a little acidosis, a little confusion, early transaminase elevation, those are bad prognostic signs. So potential management options, prevent absorption. And the best way to do that is with activated charcoal, which is very effective at binding acetaminophen. You know, we probably don't use it enough. We probably use it indiscriminately and not always in the right situations. And we tell people if they call our Center for Advice, is call us first and we'll tell you whether activated charcoal is really indicated for this substance. So try to prevent absorption, and then focus on preventing injury. So we want to prevent injury by sometimes giving larger amount of mucimist than we typically do. We match it mole for mole of toxin and the antidote, the N-acetylcysteine, and we just refer to that as high-dose NAP or mucimist. And we try to prevent further formation of NAPI, the N-acetylpyrimidinoquinone, the toxic metabolite. So we want to block that cytochrome 2E1 from forming more NAPI. Or, and sometimes they'll do all of these things, and it's common we do all these things, enhanced removal, hemodialysis, hemoperfusion, and then ultimately liver transplant is kind of the last and final step to all this. Hemodialysis, hemoperfusion, they're about equal in removal. Hemodialysis corrects the acid-base disorder better. We don't do hemoperfusion in the U.S. on anybody for anything. So we go down this pathway. If they have an acid-base disorder, they get hemodialysis. So these are options. Increase the amount of mucimist, block the formation of NAPI, try to enhance removal if you have to. It's really massive. And we usually use a level of around 900 as our trigger for dialysis, so it has to be a really high level. And they typically have to have other things going on. So, but you can find containers with very large amounts. You know, what's the dose of charcoal? You know, there's ratios of how much charcoal you need to give, but you know, paracetamol can come in very large containers in the United States. You can buy containers that are 1,000 tablets, commonly packaged. However, in the UK and some other places, paracetamol is in a push pack. You have to push each tablet out. And that was done under government rule, the idea being it's harder to push out all these tablets to overdose. You're not going to push out 500 tablets, right? You're going to get frustrated and do something else instead. And I know Australia does the same thing. So there's been a lot of pushback in the U.S. trying to come up with a similar thing, but it has shown to be somewhat effective there. As far as preventing the injury, this is the high-dose mole for mole NAP model, or N-acetylcysteine. What we do is we load them both the standard dose mucimist and the high dose mucimist have the same loading dose. And then depending on where they are on this and the time of ingestion, we change their dose, either 6.25 milligrams per kilogram per hour, or we can go as high as 25 milligrams per kilogram per hour. Now, particularly in pediatrics, this can really lead to volume overload issues, and it becomes very problematic. And so oftentimes we have to position little children, if it's very high, in a situation where they can get pediatric hemodialysis. But this is a paper by Rob Hendrickson, who lives near us, who did this study looking at ALTs and wrist line and the mole for mole equivalent. Worth reading. So, okay, so we're doing that. How do we prevent the NAFI? Remember, we try to come up with a cytochrome 2B1 inhibitor to prevent that metabolism. And you can see here, the drug is flumetazole, 4-MT, 4-methylpyrazole, and that blocks the formation of cytochrome 2B1, so it doesn't go down the oxidative pathway. Right? So it shunts it over to here, or just a millimeter. So it shunts it to the conjugation side, not the oxidative side, so you don't form the bad metabolite and get cell necrosis. Again, this is a study that looked at 4-MT, just looking at different hours of therapy by blocking the junk pathway, as well as the 2B1. So there's really two things it does. It blocks the formation of NAFI by cytochrome 2B1 inhibition, but it also inhibits the junk pathway, the C-Jun N-terminal kinase or junk pathway. So you can see in the far diagram there, ALT is on the vertical axis, acetaminophen and acetaminophen plus 4-methylpyrazole is on the horizontal axis. And you can see the two columns are 3 hours post-ingestion, 6 hours post-ingestion. And you can see the difference in the ALT by giving 4-methylpyrazole. Pretty significant inhibition. Okay? And this is at 24 hours, the bar graph on this side, again looking at ALT. And you see acetaminophen alone was about almost 5,000, but if you combined it with MAC, it was around 400 to 500. And if you combined it with 4-MP, it was even lower. Now, of course, we're doing all three, right? So we're giving the acetaminophen that's there, plus NAC, plus 4-MP. So it's even going to be lower than this. So delayed presenters, and it's really the delayed massive ingestion presenters that are the problems. They've already developed acidosis. Their levels may not be sky high, and you might have to sort of choose your therapies based on what you're seeing biochemically in their lab test. So enhanced elimination, HD or HP, benefits, correct acidosis in the vascular space, remove acetaminophen. The risks, of course, invasive, costly. It also removes antidotes. So it removes 4-methylpyrazole, it removes N-acetylcysteine. So you have to increase the doses of those to compensate for that. So there's downsides of doing hemodialysis with that or perfusion with that. You just have to be aware of that and take all of those things into consideration. Or call your toxicologist and let them help you through it. Okay? The other thing about hemodialysis and hemoperfusion is it does nothing for mitochondrial toxicity. It'll remove the lactate and it might make the numbers look better, but it's not doing anything to alter the impact of acetaminophen in the mitochondria where it's causing the damage. So just by putting someone, for example, if you just chose hemoperfusion, it's not going to impact anything in the mitochondria. And that's what ultimately causes the cell death and the damage. So, there is some scope for doing it, and the leading cause of drug abuse liver failure, of course, acetaminophen, accounts for about 50% of acute liver failure in most countries, probably more than that in the US. There's limits of conventional antidote therapy. NAP is effective if timely, but it may be insufficient. So timely being, remember, we like to start it before 8 hours. Well, patients don't know that. They don't always come in before 8 hours. So you can only pick the patients that show up to you. So if they come in late, you have to realize that it's a delayed acid ingestion, that N-acetylcysteine may not be enough to take care of the problem. You may have to up your game, depending on whether it's acidosis, how much they took, and what else is going on at that point. So indications, whether it's a massive ingestion, there's mitochondrial dysfunction. Massive ingestion, I mentioned before, is typically a level of more than 30 grams, or ingestion more than 30 grams to a level greater than 900 microliter. So again, acetaminophen has a pretty rapid GI absorption, tends to peak in 1 to 2 hours if there's no co-ingestions. It might be a little later if there's food, or it might be later if there's alterations in gastric emptying or other medications that were taken. NAPT formation in the liver occurs by cytochrome 2E1, and remember we try to block that formation. In the NAPT, we detoxify it by the glutathione that's normally in the liver. And remember, glutathione in the liver, the only thing magic about glutathione is it contains sulfur, right? So if you have a lot of glutathione in your liver, you have a good reserve, and you might do better than someone who doesn't. So malnourished people may not have as much glutathione. And the whole purpose of giving N-acetylcysteine is it's like giving them more liver stores of this sulfur donor, because that's really what this metabolite is looking for. So excessive doses of acetaminophen saturate the conjugation pathways and prolong the half-life. It gets a lot longer. So antidote roles and limitations for N-acetylcysteine: replace the glutathione, like I just mentioned. Optimally, we like to give it within 8 to 10 hours. Now, we'll give it earlier, and sometimes we'll give it if they come in and they're very close to this 8-hour mark and we're not really sure, and they have a very good story. Sometimes we'll just give them a loading dose, waiting for the labs to come back. They take an hour or so to come back. There's reduced efficacy in massive injections just because you're not giving a mole per mole, right? You're trying to get X amount of sulfur to counteract X amount of NAPT that's in there. Extracorporeal hemodialysis, rapid clearance, it's water soluble, it removes low molecular weight toxins, corrects the acid base. HP, it absorption of protein bound and lipophilic substances on the cartridges, depending on the cartridge. And for the whole extracorporeal treatment and therapy, the benefits of acetaminophen, in fact, a small molecule, has low protein binding. It's got a pretty small volume distribution. So hemoperfusion is better for larger ones and things that are bound. So again, we don't use superperfusion in the U.S. when we use hemodialysis in this regard. So time frame for beginning, again, acetaminophen, large amounts, we might consider that a mitochondrial dysfunction. We might co-administer that with 4-MP or consider extracorporeal removal if we have other signs of toxicity or very high concentration. And we prefer hemodialysis just because in the U.S. There is no hemoperfusion cartridges. We can get it started quickly, access is easy, and it corrects the acid-base disorder, which is really important. So, advantages of hemodialysis: faster, corrects the acidosis, effective for small molecular weight toxins. HP is better for lipophilic or protein-bound toxins, which isn't acetaminophen. Requires cartridges. Safety: HP is a high risk of thrombocytopenia and hypertension. A lot of that data is really from the old charcoal hemoperfusion canisters, so there's not sort of good data on that, and certainly there's not good data in the U.S. because we don't do it there. The HA320 filter, which is probably one of the more common ones used, prefers molecular weights of 200 to 60,000, coated with materials to reduce clotting, so it doesn't clot like the old canisters used to clot all the time. They're deployed widely throughout Asia, but they have a growing role in use in toxicology, and every now and then there'll be some talk in the U.S. about it. 30 years ago, we rarely used it. A few times a year in the U.S. if someone had a cartridge for theophylline toxicity. That's really the only thing it was used for back in the day. But almost nobody prescribes theophylline now in the U.S., so it's really not an issue. I think the only time I use theophylline now is in nuclear medicine stress test. So otherwise I don't use it for anything else. So hemoperfusion. Acetaminophen is small, water soluble, so it's things that make it favorable for hemodialysis. We know that NAC is significantly removed, over 40% is removed by hemodialysis. CVVH, more comparable to hemoperfusion in terms of solute removal mechanisms. Sometimes if they have a persistent renal failure, we'll go from HD to CVVH. So we'll kind of shift from one modality to the next. And CVVH can reduce clearance. Put a link to the study there. So given the similarities between CVVH and hemoperfusion, small water-soluble molecules, it's plausible that the HA320 filter may have some limited efficacy for removing NAC. We just don't know. There's not good study to guide us on that. But we do know that we do fairly well in the US without even using hemoperfusion. So, and there's no specific manufacturer data on its performance in NAC, so it kind of is out there. So practical management and monitoring these people, time of intervention, if you think you might have a candidate for hemodialysis, we get them calling a nephrologist early. In the US, we have to have a nephrologist to do HD, or critical care docs can do CVVH. But we'll call the nephrologist for these, or if they have a very high concentration. Treatment duration, hemoperfusion, is longer. Typically, we only do one run of HD, it might be a 4-hour, 6-hour run. And antidote compatibility, we continue the NAC during extracorporeal removal, but we increase the dose. We essentially double the dose because of the 50% removal because of that. So case-based, timing, dose, serum concentration, mental status, pH, lactates are all important. Think about an integrated decision pathway where we measure the acetaminophen and multiply by the ALT. If that product is greater than 10,000, it's a bad prognostic indicator, and that might be someone that we want to do multimodal therapy on with both N-acetylcysteine, standard or high dose, plus 4-methylpyrazole, and maybe even add hemodialysis to that. So this is the EXTRIP guidelines looking at this and where it might be indicated, and essentially they kind of come out for dialysis on this. So what do you do if you are working in a remote area and you can't get into acetaminophen concentration? And that's not unusual. This happens in the U.S. not infrequently. We have to make this decision. How do we treat this patient? Well, overdose patients, at least in the United States, the history is notoriously poor. We say 50% of the time they won't tell you, and the other 50% of the time they're lying. So we never really know what they took. And that makes it difficult. So you have to use your best clinical judgment, assess them, whatever their history is, look at their LFTs, measure acid-base status, lactate, and your acetaminophen concentration. And if you're worried, if you can't get an acetaminophen concentration and they have elevated LFTs, we just start them on N-acetylcysteine. And if they're acidotic, then we would transfer them to a center that could potentially do hemodialysis. That would be our approach. So it's not someone I would just do hemoperfusion on in a remote area. First of all, we don't do hemoperfusion in urban or remote areas because that doesn't fit the acid-base side of this, which is an important point. So we use standard dose N-acetylcysteine for most things. For massive, we consider omeprazole and high-dose NAC. Low concentrations of acetaminophen or no elevation of acetaminophen, we typically don't give omeprazole. Some people say if there's no acetaminophen detected in the acetaminophen overdose, that it's been too long, that they won't even give N-acetylcysteine, that its benefit is gone by. And the studies are underway to determine right now whether we should just use omeprazole or 4-methylpyrazole, the same thing, because of its ability to block the junk pathway. So you still have that benefit to block the junk pathway, even though you can't do anything about the cytochrome 2E1 pathway at that point. And then for functional liver failure, typically we measure coagulation factors. Factor 7 and protein C have the shortest half-lives. And so we use those as measures of someone whose liver is not recovering and might need a transplant. So if someone we think is going down that pathway, we'll do serial factor 7 and protein C levels, and while we're treating other things with them. So that, there's just some references there, and thank you very much.
Any questions? So I have one question to you, Professor. I saw from your slide that NAC compromised the liver regeneration. NAC compromised the liver regeneration. So how do you treat the patients with NAC in liver failure? Patients with liver failure, you will treat them with NAC for until the clinical of the etc.
So it can cause impairment of that pathway, the NAC, but what we would do is use other modalities with it. So that's where we would use 4-methylpyrazole to block the formation of those DE maps that are causing adjacent injury and toxicity by blocking the junk pathway. So it's kind of like you have to balance it out and kind of do a dance. And it takes a lot of decision making to figure out which pathway to use. Again, a lot of this is kind of experimental, but with a massive ingestion, you just have to do what you can do. So.
Dạ, em có câu hỏi cho thầy là trong ngộ độc acetaminophen thì cái tổn thương ti thể thì em không biết là cái vai trò của các loại vitamin, ví dụ ở đây là vitamin C chẳng hạn, thì nó có vai trò gì trong cái việc mà bảo vệ cái bào gan khỏi cái tổn thương này không?
So the question is, in acetaminophen poisoning, so we observe the mitochondrial toxicity, and we know that the mitochondria electron transport chain work under a very complex matrix that involves a lot of cofactor and vitamin. So is there any role for vitamin supplement in order to restore the electron?
That's a very interesting question, but it hasn't been studied. There's some thoughts about coenzyme Q10 because of its supported mitochondria, but there's no hard data yet. There's so many of these studies that are just, it's just very early on. So there's a study waiting to happen if you want to do the research.
Dạ, câu trả lời của thầy thì là mặc dù rất là thú vị nhưng mà chúng ta chưa có nhiều cái dữ liệu về chuyện bổ sung vitamin để mà cái hồi phục cái chức năng thiên thể của bệnh nhân. Mặc dù là trước đây có một số nghiên cứu là bổ sung cái coenzyme Q10 nhưng mà chưa được bằng chứng gì là rõ ràng.
And because this is sort of a complicated scenario and the patients can be very different, this is really where the medical toxicologist is really valuable to help you weigh all of these decisions in the emergency department or the critical care unit and say, what do you think, and come up with a treatment plan because, these patients, they'll die, there's no question. So it's always good to share the decision making. Okay, thank you.